Good morning. Good morning. This is the SANDATA Pennsylvania DHS Alternate EVV Town Hall. Thank you for attending this morning. This is a general overview of the alternate EVV process for the Pennsylvania DHS program. This will be a live event, so please remember to mute your line with your microphone icon or directly mute your phone if you're a dial-in participant. If you have any questions on this presentation, please feel free to post those questions in our Q&A feature. That is located at the bottom of your screen and says Q&A. You may not be able to see your question, but you will see any answer that comes through to you. We will address questions periodically throughout this presentation. We'll stop and make sure that we get as many as we can in the time that's allowed. Also, please be aware that these presentations will be provided after the fact. We'll give a copy of the slide deck as well as some information on the other questions that were asked so that you can check if your answer is present among them. We welcome feedback. You will get a survey after this webinar to help us improve this process moving forward. That is a great time for you to ask any additional questions that you might have. I'm going to turn it over to John Kalivas. He will be presenting today the information for this alternate EVV town hall. Thanks, John.
Good morning. Thank you, Chloe, for that opening. I want to also extend my welcome and thanks to everybody that's attending. As Chloe mentioned in the opening, we're going to do a quick overview of the alt-EVV. We know that for PADHS, this has been in play or in production for well over a year now, I think pushing over 2 years at this point in time. But what the town hall is specifically geared for and aimed to is provide additional questions, an overview of what's in play, and then some common troubleshooting issues that can help you resolve issues as you go forward. As you'll see when we get to the end of the presentation, there are ways and methods for you to transmit your data that will increase your success rate. So as we go forward, as Chloe mentioned, please use the Q&A function. As we get questions, as we go through the addendums or as we go through the overview, we're going to group those questions together. We'll answer some of those live in the call, especially when we get common or recurring themes. The point of the town hall is not to answer individual specific rejects or ticket questions, but again, to inform and provide guidance to each of the vendors or each of the agencies as they move forward and get fully integrated into the program. So today we'll start, as I mentioned, an overview. We'll talk about the addendum and the JSON, and then we'll go through those common issues. At the end, I've also provided a few tips and tricks, as well as some helpful resources that'll also help you in your troubleshooting efforts so that, again, you can become fully integrated in the program. So from an overview, many of you, if not most of you, have already gone through the registration process, but we wanted to bring it up again. So if there are new vendors or there are new provider agencies that are just coming on board, SANDATA has adjusted the process for intake and onboarding slightly from its original inception. So when the individual provider agency, you are new, you have not integrated with the PADHS program and you're new to the solution, you will reach out to the PA alternate EVV email address and you will receive a small survey consisting of 3 to 7 questions that will help us identify the provider agency and the vendor who's collecting your EVV visits. From there, SANDATA will take over and work directly with your vendor to onboard that vendor through testing, certification, and checklist. So the vendor themselves will also receive a small survey if they're new. So existing vendors that are already compliant with the PADHS program will just move additional provider agencies into the production environment through account creation and credentialing. If we do have a new vendor, the certification process kicks off after the survey, where they begin to integrate with our 3 endpoints. We're going to require them to send client data or beneficiary data. We're going to ask them to send their employee or caregiver data, and then send visits associated with those 2 pieces of data, our clients, members, beneficiaries, and our employees. that target and match to the addendum information within the specification itself. Once that's been completed and reviewed, we test both positive and negative test cases. Credentials are issued to the vendor, and the vendor is then allowed to move into production. The last step for aggregator access, this is directly for the provider agency themselves, is to go through a training that allows you to access the data stored within the PA/DHS aggregator on behalf of your vendor for your particular agency. You'll use the aggregator for troubleshooting. For instance, if I send a visit and it is rejected because it doesn't have a client ID, I can check the aggregator to ensure that the client record is found under my provider agency account. And if not, I need to retransmit my client ID. We'll get into more specifics about that troubleshooting a little bit later in the presentation, but that's a way that you can use the aggregator to leverage and verify the information for my agency has been successfully written to my account. So now we'll move forward and go into the JSON and the addendum itself. So the addendum for Pennsylvania has several different flavors and options based on the integration point that you have in the field. So the fee-for-service state population has its own addendum. The MCO CHC population has its own addendum, and the OMAP populations have their own addendum. Each one of them varies slightly from a service code, payer, and program combination perspective, and we know that several agencies use all of those combinations. So we work with the vendors themselves to make it as easy as possible to integrate with the Pennsylvania aggregator. So the addendums themselves are posted on the PA/DHS website. They have an alternate EVV webpage that shows all of the addendums that have been posted. It also has an error handling document. So we've recently posted an error handling document that allows you to better troubleshoot on the vendor side when you're submitting data and it's being rejected, what those rejection or error messages look like, and what action to take in order to correct those items. The addendums themselves, while different from an appendix perspective, the intake of each of those items is exactly the same. So we want to collect our client information or our member information. We want to pass and send our employee information. And then we want to send in all of the visit information that matches or aligns to the client IDs and the employee IDs that I just provided. So we'll start the overview with client. Client is our most important intake because it sets the stage for accurately collecting information in the field and accurately storing the data for my agency that will ultimately match to my claim. For Pennsylvania, we have 3 segments for the client record that are required. There's 4 that are defined. The client phone number is optional, but it's highly recommended that you send. For the client records themselves, we're looking for client general as the main segment, client payer, which shows the payer program and service for that individual, and the client address. Address is a key element because it's required for cures. Again, client phone is optional, listed as optional in the addendum itself, but it's highly recommended if you have a phone number that you transmit that all 4 of these pieces and not just the 3 items that are required. Each of the addendums will list our identifiers. So we have a provider identifier that's used for matching, the provider ID for most programs, other than those in OMAP, physical health MCOs, is the 9-digit PA/DHS Medicaid ID. For the OMAP physical health MCO population, we are using the provider's MPI as the transmitting data element. For the client identifier, we're using the PA/DHS Medicaid ID. This is issued and sent to SAN data from the Pennsylvania source systems on a weekly basis and used for matching when we do the intake. So from a validation perspective, we're going to match the provider ID to an existing account. We're going to verify the length of that client ID. We're going to match to the PA or Pennsylvania provided source data for the member. And then we're going to check for each of the required segments that I talked about above. If and only when all of those items pass, does the record actually get written into your account? The client ID must be found within your account in order for you to send visit data that matches. If my client ID rejects for any reason, I must retransmit the ID. I log in and check in the aggregator that my member was now transmitted, and my visit will successfully be posted to my account. Clella, any questions on client that may have come in?
We do have a couple of questions, just kind of for the general group. I know that there is some specific answers that have been, provided, but what is client general?
Client general is the name of the segment or the name of the JSON segment that will be provided. We'll go through that on the next slide so I can show you a little bit more detail on how you find that.
Great. We were told by Sandata Tech that we could use the same submission credentials for the OMAP physical health MCOs and did not have to use the NPI. Has that now changed?
It has not. So if you were specifically directed that your account includes multiple populations, you can continue to send your 9-digit ID, and that will match to your account on the PA/DHS side in the aggregator, and data will be stored successfully.
One other question from an earlier section, will we have to recertify for the HHCS services if we are already successfully extending existing services?
That is yet to be determined. We don't believe we will do another round of testing, but we will conduct an additional town hall to show and provide the additional information as the Pennsylvania team defines what that new integration looks like. We will provide more information. Again, at this point, we don't believe there's additional certification required, but we will want to make you aware of what the changes are that are coming down the road.
Okay, here's one that's just been put in. We have been calling in and logging out. However, it is not being seen in the system. How can we confirm? They are using a 4-digit client ID and are unclear which one to use.
So per the specification, a 4-digit client ID is not valid. So in hearing the context, and we'll do a little bit more research based on who submitted this question so that when we post the formal responses, we'll get an answer specific to that individual agency. But in general, the client ID is the 10-digit Medicaid ID. When I hear that there are 4 digits in the client ID, that means the client record rejected. Therefore, any visits associated for that client are also being rejected. So the guidance and advice is to resend the clients with the correct PA/DHS Medicaid ID, and then check and log into the aggregator and ensure that your members are being loaded successfully into the account. Once that is complete, you can begin to start resend or retransmit your visit information. So moving forward to the client JSON, and this goes to the question on client general itself. The JSON in format is hierarchical, and those that are technical on the phone, it semi-relates to XML from a formal layout perspective. I put snippets in here from a lookup perspective, so each of the addendums will have a provider section. In here, where it says client general information, this is typically the client's first name, last name, and that unique identifier. In this case, we know it's the PA/DHS Medicaid ID. And we're going to fill in this segment with all of that information. For Pennsylvania, we have 2 sub or child segments that also need to be provided as required. One is the client payer information. This is going to include the payer ID, the program ID, and the procedure code or the service code or HCPCS code that's been authorized for service delivery. A list of those service codes can be found in the appendix of the addendum specific to that particular population. The child segments can also be repeated. So if I have an individual that has more than one authorized service for delivery, you can send more than one client payer segment within the same transmission. The client payer and the client address are child segments of client general, and can be repeated. So I can send in multiple address segments and multiple client payer segments. It just needs to be well formatted JSON. The other screen over here is our client address information. In both client payer and client address, we recommend sending all of the fields that are associated there. So ensuring that we have address types, ensuring that our payer program and service code or procedure code matches to the appendix in the addendum so that I get an accurate record and it doesn't prevent my client from loading to my account. Most of the vendors that we work with are familiar with this JSON format, and many of them are integrated and sending data successfully. So as we go a little bit further, I will provide some tips to those that may be struggling a little bit on how to verify and review your account to ensure the data is being received correctly. The next endpoint that we're going to send is our employees. So we know from Cures we need the two who's: who received service and who provided service. The first one was our client or a member segment that we just sent in. So now I know who received service, or all of those that are potentially eligible to receive service from my agency. This segment is our employees or our caregivers, our care workers. This item, there's only one segment that's required, and it's required for all of your caregivers that provide service in the field. Just like our client segment, we're going to send in our provider ID. So our 9-digit PADHS Medicaid ID, or for those that don't or aren't familiar with that, and the OMAP Physical Health segment, the 10-digit MPI. Same checks apply to this ID as it applied to that first ID. So we're going to check to ensure that we have an account that matches to those IDs, and the credentials that you provided also align to that ID. Then we have our employee identifier. So there was initially set to only the last 5 of the SSN, padded with leading zeros. PADHS heard the conflicts that arose from having that method. So they've expanded what's being provided or what's being sent in that field. We'll review that on the next slide. But from a validation perspective, what the SAN data system does is it checks the employee identifier to ensure that it matches one of the 3 possible values that will be sent in the employer identifier field. Next, we're going to match that ID to data in your account. So if we successfully pass the validation layer, we pull the ID that you've just transmitted. If there's no matching record, I'm going to insert a new. So that becomes a new employee record within your agency account. If I do have a match, I'm going to update the information that was just provided for that account so that I only have my employees listed once within my agency account in the aggregator. Just like clients, employees have to be found within your account for your agency and viewable in aggregator before I can associate a visit with that information. If I send visits for an employee that's not found, the visit itself will reject. Identifiers. It's a little hard to read on the screen, but it is listed within the addendum, but I wanted to put all the information in here so that everybody has it within the slides. So PADHS expanded and approved the ability to send in multiple identifiers for our employees. One option is to send a new generated ID with a 2-digit vendor-specific ID. This is listed in the appendix of the specific addendum, along with a system identifier for that employee. In the example we provided, it was AA, and the ID was 00123456, which concatenated together puts AA 00123456 as the ID. The intent of this new ID was to remove the duplicate issue that was occurring when only providing the last 5 of SSN. The second method is in the PADHS Unique Registry ID. The Pennsylvania teams and the Pennsylvania program offices are taking steps towards implementing this for all caregivers across the state or the Commonwealth, so that each of those caregivers or employees are uniquely identified across the state. This has been rolled out for some of the program offices and some of the vendors, but not all. So it's highly recommended for those that do have a PADHS registry ID, because we know that it's unique for that individual caregiver, that you send in that information within the employee identifier field. And then if neither of the first two start, we've left in the ability to collect or consume the last 5 of the SSN with the 4 leading zeros as padding. So this will result in a 0000 number check. Because we know the last 5 of SSN is not unique and only unique across each 100,000 individuals with an SSN, you do have the high likelihood of getting rejections when using that information. So please refer to the addendum for additional details there. The addendum itself, again, has the appendix with the vendor-specific IDs. And we found through discussion and working with the vendors that this has resolved many of the issues with the conflicts and employee identifier. Clella, any questions on employee that may have come in?
No specific questions on employee, and I don't see anything that's related to the information that we've covered so far. I do have questions on visits, so I'm going to let you speak to that, and then we'll go ahead and ask those specific questions.
Perfect. Yep. So let's move forward with visit, and then we'll get to your specific questions. So visit ties everything together. So from a cures perspective, we just talked about the 2 who's. Now the visit provides us, when did this occur from a duration perspective? So I need a clock in and a clock out, or a time in and a time out that gives me duration of service. So how long or how much service did I provide to that individual in the field? I also need location. Within the visit, and when you use a mobile technology or a technology that is GPS enabled, we want to get the GPS coordinates for where that visit occurred, so that we know how and where it was defined. In Pennsylvania, we record the GPS, but we're not throwing an exception that will stop or prevent the visit from loading. But the visit itself is made up of multiple segments. So there's one required segment, which we refer to as visit general. And anytime you see general in the header, that means it's the base or the parent for that individual endpoint. So we have our visit general information, and then we have 3 conditional segments. We have 1, and each of these are child segments that mirror what we talked about in the client record. We have calls, we have visit exceptions, and we have visit changes. For our provider intake, we do the same match. We're going to match to the ID that was provided in the JSON, ensure that the username and password that was associated with the authentication for the endpoint matches and aligns so that we get data into the right account. The other items that we're going to check is our visit other ID as a requirement. The visit other ID is the ID associated with your individual vendor system, so that if we need to do some troubleshooting or if we need to do some verification, you have a way to find which visit matches to the visit in your system. Client identifier and employee identifier, as we've talked along, have to match to the information and to an existing record in my account before they will be validated. So in the visit segment, we don't check against the state data or against any other information. We use the data that's been stored in the previous 2 transactions for reference and matching to load the data. In the visit, we also take it a step further, because we know from a cures perspective, we need to verify the procedure code that was provided, which defines the service that was authorized either through the MCO or the PADHS team, and used through identification. We match the payer ID, so who is that source for that authorization, the program that it was associated with, and the procedure code for that individual service. So if all of those match and align, the visit will be recorded. As I mentioned on the previous slide, my client identifier and my employee identifier must match to a record that's already been sent. If I don't have a matching record, then my visit information will reject and need to be corrected in the source system before being retransmitted. The optional segments, our calls, our exceptions, and our visit changes, are only sent when updates, changes, or issues occur. For instance, if I didn't collect a call in the field, I would need to send an exception acknowledgement and potentially a visit change if I've already transmitted that segment or that visit into the PADHS aggregator. The addendum itself will provide guidance and specifics into when those items, those particular segments are required and when they're not required. As I mentioned on the previous slide, our service code and modifier combinations are the key to the setup, and we match the data in unison. In a later slide, there's an exception thrown for service ID not found or no match. That occurs when my combination of payer, program office, HCPCS code, and modifier combination in order doesn't match to a specific record defined in the addendum. If I send the modifiers out of order, or I send in a service code that hasn't been defined, that individual visit record gets rejected back to the vendor. And again, the data needs to be corrected in the vendor source system by the agency and then retransmitted so that the visit information is successfully loaded into the system. Each of the addendums that have been published for each of the specific groups, MCO-CHC, our fee-for-service population, our OMAP fee-for-service, our OMAP physical health, each has a slightly different list. So please review and ensure that the list for the population or list for the service or list for the individual member and where that authorization came from matches and aligns to that addendum. So Chloe, I'll pause there because I believe you said there's several questions from a visit perspective.
There are, and there's a few that are from both the client section and the employee section. So I'm going to catch those up first.
Yep, sounds good.
We've been asked, how far back can we go to correct a client who continually is rejected?
So the start of the program was October 2018, and that's the furthest back date that you can send data for. From a CMS compliance perspective, January of 21 is the drop dead compliance date. So from a client perspective, you can go back as far as you need to from a delivery perspective. Visit information, PADHS was looking for all visits if you were in program at the start from 2018 forward. Mandatory compliance 21 and forward.
And then let's go ahead and touch on a couple of employee questions. What program offices have rolled out DHS unique registry? When you say that the masked SSN is being phased out, what is the timeline?
We don't have a full timeline for the registry. It's an active project that the PADHS team has on their plate, but with moving forward with the 23 initiative and some of the other items on the plate, it's not the top priority project. We will continue to inform and update this group as we move forward and when those things will be phased out. There will be time for you to make adjustments or changes or registry based on when that information rolls out, when it's going to be required. So it will be some time before that is all completed. We will use town hall forums as well as notifications to keep everybody informed of our progress as we move forward.
Great, thank you. What if we use our own internal system and not a vendor? How do we obtain a vendor-specific ID for the employee identifier changes? Is that something that we'll need some help from the Pennsylvania team on?
Yeah, let's note that. We'll see who submitted that, and then we can get a specific update out for them.
Not a problem. All right, we'll go ahead and move on then with some of the visit questions. I am going to kind of lump a few together, but we'll answer some specifically. We have an
Yep,
ongoing
perfect.
issue related to the phone in option. If a client has no home phone, or more frequently, if the visit starts or ends at a location other than the client's home, the call in or out cannot be done without an exception. These exceptions count, we assume, against our success rate. We'd like input as to how we are expected to deal with these scenarios. I guess
So
we
an
haven't gotten there
exception
yet,
that,
huh?
well, so no, and it's a good question, and it's a fair question. So exception doesn't count against data. So as long as we're using a technology to capture our call in and call out, sending an exception acknowledgement doesn't negate or invalidate that record. It just says that I acknowledge that I used a phone. In our case, we call it unmatched client ID and phone. I used a phone that was not at the member's home. From a program design and setup perspective, that's totally acceptable. You send in the acknowledgement with the time in and time out from the phone that was used to collect the visit information, and it records as a TDV or telephony phone in and phone out, with an exception of I acknowledge that I wasn't at my client's home address or home phone number, and the visit gets loaded correctly.
Great.
That specific use case, I'm going to put in some more details when we post the responses online so that you can see that specific use case and how that will show within the aggregator as a completed or verified visit.
Excellent. We have several calls or several Q&As that are regarding the manual calls or missing call out and how to make sure that they are able to update records. And I believe you did handle that with the discussion, but if you could just kind of review quickly how a manual call or adjusted times would be used.
Yep. So, and that's another valid and fair question. Similar to the last response, we'll get a more detailed update out in documentation as a response to those questions or those group of questions around those. But there are two methods to be able to send in a manually created or a missed call in or call out. We have adjusted times. Adjusted times can be used in two scenarios. One, I need to adjust actual times that were collected using one of my technologies. So I use my mobile app or I use my telephony call in, and the caregiver themselves clocked in 5 minutes late because they forgot, and I need to adjust it back to the top of the hour. When you adjust a visit or when you manually create a visit, you can use those adjusted times that will require us to send in the visit change segment to include a reason code on why it was missed. Caregiver forgot to clock out, caregiver forgot to clock in, but then it doesn't force the vendor to be able to or need the ability to create a manual call. The other way that I can send in a manual is to create a call by hand or through data entry. In some of the vendor solutions, you're able to call in or you're able to create those calls through call type of manual and insert or add the ending time or the clock in time that was missed. So I manually build my second segment for anything that was missing. My call type in that segment becomes manual, and I insert my time either in or out, depending on which one was missed, and send the visit with my visit general, my call segments, and potentially my visit changes if you're updating a visit that was already transmitted. I will put in more details because that's a pretty complex workflow. I'll put in more specifics into the responses as we get them documented so that you have specific examples of how that works. In the Pennsylvania provided solution, so in their EVV state provided solution, there is the ability to manually create that record in the system and mark it as a manual visit. So in our case, or in the Pennsylvania vendor system case, we don't use the adjusted times in there. We just use a call type of manual.
Okay. What if the third-party system isn't sending the adjustments to the aggregator?
So adjusted times, so actual times for delivery are used when adjusted times are not present. Adjusted times in most cases are to align what you've submitted from a billing perspective, where your caregiver clocked in or clocked out, either too early, too late, or whatever occurred. When I use adjusted times and I don't send adjusted times, my actual time may be less than what I billed for. When my actual time is less than the units that I have billed for, the claims validation step through the adjudication process will reject or mark or edit that claim as not valid. We are looking for visit times that match to the units that were billed in your 837s. So if I've collected an hour's worth of time, 60 minutes, and I bill for 4 units, but I only collected 50 minutes worth of actual visit time, that will calculate to 3 units, therefore not 4, and it will give you an invalid or no matching visit for that individual claim. In those scenarios, I can adjust my visit. So I could do an adjusted time that gets me to my full 60 minutes, resend the visit, which will update, transmit my claim or resubmit my claim. Now I have the 4 matching units that matches my unit, and it will be paid correctly. So to restate, times for visits must match to the time we're billing for.
Great, thank you. We have a question. Where will the detailed response document be accessible?
We're still working on location, but I'm almost positive we will put it on the PADHS website in that alternate EVV section as a new section with the slides as well as the Q&A.
Great, thank you so much.
So what we have on the screen here are exceptions. So we talked a little bit about exceptions. Think of exceptions as non-compliant data for program policy. So we know that for the first 4 on here, those are all cures related elements, and I must receive those 4 items in order to have a valid visit. The first 4 items will all reject a visit if I can't find a matching information or the HCPCS code or service code doesn't match to my definition in the addendum. So those are all going to be rejected back. Your vendors have the ability to call us to make a status call after they've sent their transaction. And in the status call, it will tell you which of the records has rejected or not loaded correctly. We'll talk about those rejections specifically and how you can handle those rejections on the next page, but want to spend a minute here on the other 3 items that are listed here. So unmatched client and phone number was the topic that we just responded to from a TVV perspective, where I'm not using a phone line that's associated with my client. In the client segment, if I send the phone numbers that are associated with them or any of the phone numbers where I may call in from, then that exception won't trigger because now that phone number itself is associated with that client. So that's where it's recommended that we send in our client phone number segments so that we avoid this exception from occurring. The other 2 are call in and call out. We know that there's the ability, and CMS provides us the ability to send in manually created calls or manually adjusted calls. So when I don't have a call in and I don't have a call out, the visit itself doesn't reject, but it is set to an exception state. To be compliant with cures, I need both a call in and a call out. So in my source information and how I correct this information in the aggregator is I include the missing element, call in or call out, in my source system. I resend my visit through my visit other ID, so that's a matching ID, and we can locate that record in your account. And I include a visit change log. Why am I retransmitting this visit record itself? Through the use of a reason code. The reason code just says I acknowledge that I didn't collect an out call, for instance, at the time of visit. So I need to update that visit so that I can match from a claims perspective and get paid for that individual service that was provided. So again, the last 2, update in the source system, retransmit so that it updates the data at rest for your account so that we can match to that claim when it goes through billing. So now we're going to jump into some support issues. Many of you or many of your vendors may have received this error. I put it in here for any of the new vendors or potentially new agencies that are coming on board. But one of the error messages that you'll get if your setup is not correct is invalid credentials. What that means is my provider ID, username, and password that I'm using for authentication don't match. So either the ID, my PADHS Medicaid ID, or the combination of username and password is not set up correctly on this vendor system before sending to us, to the PADHS aggregator. In most cases, this is corrected early, and since the password, username, and passwords don't expire, once it's corrected, we rarely, if ever, see this issue occur. The most common issue that we're going to get is client ID not found. We know in the previous slides we talked about the PADHS team is sending us a full eligibility file for all clients that are eligible to receive services. When we receive that information, we are going to match to that individual, that ID to that PADHS provided data file before loading the client into your account. If you see a client ID not found and I'm transmitting a client record, it means the ID didn't match to the state or the Commonwealth provided data. If I get client ID not found and I'm transmitting a visit, it means my client is not loaded into my provider agency account in the aggregator. So in both cases, what we want to do is retransmit that client record, log into the aggregator, and check to ensure that that client was successfully loaded and it's viewable in my aggregator account. Then I can begin to start and send my visit information for that individual. The next there is workers. So again, we need to get our clients and our workers loaded into our accounts. Workers, just like or similar to our client records, we need to ensure that our worker information has been fully loaded into my account using one of the client identifier methods that we showed in the previous screens. So we want to ensure that all of our caregivers, not when they were providing service, but all that our caregivers that can potentially provide service have been transmitted. If I get a worker ID not found through my visit intake, we need to check again through aggregator that the worker record is found and then retransmit our visits. The next one is the service ID. Talked about this periodically throughout the presentation, but we're matching on several data elements, not just the HCPCS code that I'm going to bill for, but I'm also checking the combination of payer program and modifiers if I'm going to use modifiers in my bill. I want to ensure that all of the information that I receive matches correctly. So when I'm transmitting a visit and I get a service ID lookup error on my status check, it means the combination of payer, program, service, and modifier didn't match or didn't align to a record defined in your addendum. The second time we'll get this is order. So our modifier from a combination perspective is also order specific. In the case that we put on the screen here, we have a U4, U1 for W7060. If my vendor transmitted that as W7060 U1, U4, that will actually reject. So the combination itself is valid, but order is enforced and it does matter. So we need to ensure that we're matching there. In both of the last two service code slides, those need to be corrected in your source system, updated and checked to verify that it aligns to the addendum, and then that visit information, because we can't store it without a valid service code, it was rejected. So in order to send that visit record, we need to send in that right combination. If I don't retransmit my visits, that visit for client not found, worker not found, or service ID errors do not exist in the PA aggregator and will not be found when we're doing claims validation. So again, I encourage you to log into the aggregator, check your clients and employees, but check that your visit information is actually residing and visible in the system and is in a verified status. Pause there, Cleo, before we go into some best practices and some resource links. Any questions pop up during that?
There were a few
Cleo,
questions that kind of were right at the very tail end of our last Q&A session that I wanted to make sure we addressed.
Yeah, absolutely. Let's do that.
Great. So does an agency edit approval to a mobile punch adversely affect its ability to be billed successfully?
It does not, right? So cures, we know that you cannot be 100% reliant or compliant in all cases for all scenarios. So adjusted visits do not impact the ability to bill. The key there is time, right? So we're using the time duration of the visit to use the billing rules that PADHS has applied on their website and published to everybody. We use the same rounding rules that they use within the Promise or MMIS system, and we calculate time to units. So if my unit calculation is less on time than I bill for, that will get rejected as no visit found because I haven't collected enough EVV visit information or service time to approve the payment of that particular claim.
Okay. We have ODP cases where the employee starts at the client home and finishes the visit at a different location or vice versa. This does just create a discrepancy with geolocation. How do we report this? Do we have to submit two addresses for the client?
So address doesn't have to be there, right? So we know that through PADHS policy and program offices that in-home and community services are valid. So the only thing we need, and we don't have any GPS location specifics enabled for the program. So what that PADHS team has done is through our call segments, I can have a call in at one location and a call out at another location, and it's simply used to comply with cures, but there is no adverse action or no additional requirement that the agency has to take in order for that to be a valid visit. So it's perfectly acceptable to have GPS at one location for call in and GPS for another location for call out. And again, no exception occurs, and there's no reporting or issues with that being a compliant visit.
Okay, as a follow-up to the discussion we had on manual entries, there was an additional question about what documentation is needed.
What CMS has advised and what CMS has guided.
John, you cut out there, so.
Somebody muted me, I apologize for that. What CMS has guided us onto is that you can use any paper written documentation as written notation or written proof of that visit. It doesn't need to be transmitted to the PADHS aggregator. It doesn't need to be provided anywhere else. It's simply used for auditing. In most cases, I've seen some use timesheets, their old paper timesheet process to document that encounter, store it on site. Most cases you won't need it, but that should suffice from a documentation perspective.
Okay. If the visit EVV time is greater than the scheduled build time, will this create an error, or only if the visit EVV time is less than the build time?
So I'll have to read that one and get more details because I think I understand it, but let's just talk to time in general. So again, from a billing perspective, what the bill is going to do is it's going to be adjudicated and I'm using fee for service. So it's going to get sent to the Promise system for adjudication or payment. It's going to check the units billed within that claim against the EVV visit time that's been collected. If my time calculation is 45 minutes, which equates to 3 units, and I have billed for 4 units, I have less EVV visit collection than I billed for. Therefore, that claim itself will get rejected. I need visit time to match or exceed what we've been billed for. So for instance, if my caregiver clocked in a few minutes early to the top of the hour and a few minutes after the top of the hour because they did a clock in and clock out from their car after providing an hour's service, I would have, say, 65 minutes or 67 minutes worth of time, and I'd billed for 4 units. So anything that exceeds that time from a collection perspective will still get paid because it exceeds the number of units, calculated units that I have on my bill.
Great.
Only when it's calculated to less do we reject.
Okay, thank you. If we put a reason code on the first send where we have no out call, do we need to resend as described?
You do not, right? So we need to collect the reason why I didn't have an out call. The visit can include the manually created call, and that can all be sent in one transaction. So if you've collected or identified that before it's transmitted to aggregator, you can make the modifications and the adjustments and then send it as one transaction where you don't have to repeat that integration or that transaction.
I'm just taking a look here to see if we have any really recent ones that we can answer here. Let's go ahead and move on. We're running short on time.
Yep. So just about 8 minutes and about good timing. So just want to talk through some best practices. So I've been mentioning this along the presentation, and we just want to reinforce it as we go forward. From SANData's perspective and working with vendors in the space, we highly recommend, we can't require, but we highly recommend you send in all your clients for any time they would expect service, not just when the visit occurred. I could send in my clients one time, and I only update clients, which is a little bit further down, when information from my client has changed. There is no reason to send clients every time you send a transaction. So in most cases, in the vendors that I've worked with in the field, they are sending all of their client information, and then that transaction or that endpoint is not used again until a client record has been updated or a new member comes on board for my agency. Once your vendor has acknowledged that they send clients, I recommend you log into the aggregator and just ensure that your member list matches to your source system. Take that time to adjust and make sure that all of those records are loaded successfully into your account. Same for employees. Now that I have my members loaded, I want to send in all of my service employees or all of my caregivers. I don't want to wait for the caregiver to provide service. It's better to send in them all into your account and have them available so that I'm only targeting and I'm only resending or transmitting my visit information that's been collected. Same process as clients. Send all your member record or all your employee records in, log into aggregator and check and do an audit. Make sure your two systems align, that my data at my DHS aggregator matches my source account. Once I've done both of those, I can retransmit or I can send visits. I know that the IDs within my visits will match to the data within my agency account, and I have an increased chance of that visit being loaded correctly. We've seen a huge increase in success when you follow this pattern. So as I send visits, I continue to send my visits on whatever schedule my vendor has approved or whatever schedule your agency uses to perform your visit maintenance or ensure your data is correct before transmission. I recommend that you send all of your visit data before you transmit or send or submit a bill. So before I'm going to send a claim, I always want to ensure that I've sent all my visit information to the aggregator so that as the bill gets adjudicated or the claim gets adjudicated, I have a matching visit information. And then I mentioned at the opening, we're going to retransmit clients and members as things change. So if I get a new caregiver or I get a new member, I want to send all that information in. Or if I get an updated address, I want to send in my client information again. Keep the data as clean as possible, but highly focus on just the visit information once your clients and employees have been loaded. From a support perspective, we've done a couple of things. So we've expanded. The PA-DHS team has worked to add all of the documentation into an alternate EVV page on the PA-DHS website. As I mentioned earlier, it now includes an error handling overview document that provides more detail on each of those specific error codes, what's accepted from a formatting perspective, and what we're looking for in each of the fields that will help with front-end validation. There's multiple sections within that web page. One is the addendums themselves. Another is these helpful hints and tips. We'll also be posting these materials. So the slide deck, as well as responses to the questions you've asked along the way, so that you have one place to go forward and review the information. If you have questions and need support, use the PA-DHS Alt EVV email address, and that will go to the SAN data support team, who will route that to our alternate EVV team so that they can reply to your questions. The Alt EVV team is expanding, and turnaround times from a ticket perspective are shown to be decreasing, and we'll get to your question as soon as we can. The last item on here is an SAN data Alt EVV resource website. So the SAN data marketing team is working on an additional web page that will be state specific, or in this case, Commonwealth specific, and provide some details, not only at the state level, but in general, for how the SAN data solution works. It will have a way for you to get notifications on if there are things that are changing or if we're encountering problems. And it will also provide some, again, helpful tips and tricks and FAQs that will help you be a little more self-sufficient and troubleshoot your issues. That should be rolling out in the next month or so. We'll send out notification when those resources are available. In most cases, it'll be targeted towards your vendors and not specifically to the provider agencies themselves, unless you're an agency that has its own solution. So it's going to be more tech forward and tech specific to help those vendors be more successful with the integration. Clella, any last minute questions before we wrap for today?
So we've got about 2 minutes left, so I'm going to just ask one more question. I know there are a lot of really great questions in the Q&A chat, and we will be addressing those and sending those out, as John mentioned, to the PA website so that it's available for people to peruse. Even if your question was not asked today, you may be able to find your answer there. So I apologize that we won't be able to get to everyone. In a previous slide, you mentioned that visit overages must be corrected. In the slide, you mentioned that a timesheet should suffice. He's saying that this is conflicting information. Can you clarify?
I'll have to take that one offline and answer it a little bit more easy, but written documentation is different than providing adjusted updates and edits, right? Written documentation says my caregiver in the field failed to take action for clock in and clock out. Adjustments are used to align my visit to what my service was provided in the field in order for my bill to match.
Exactly. So they're not mutually exclusive.
Yeah.
Yeah.
So we'll provide a little bit more detail on that in the written documentation.
Great. All right, thank you so much, John. That was a great presentation, really great information. Thank you to all of the participants, excellent questions. This is going to conclude the alternate EVV town hall for the Pennsylvania DHS system program. Have a fantastic day, and we will do our best to get those answers to you as quickly as possible. Thank you.
Thanks, Clella. Thanks everyone for attending. I appreciate it. Have a wonderful afternoon and happy Friday.